Good morning, everyone. I am Valyumer Basul, and I am going to report about the fetal heart tones or sounds, fetal heart rate monitoring, and the ITS interval. The learning objectives discuss the advantages and disadvantages of external versus internal fetal monitoring. Be able to interpret the fetal heart tracing, such as the baseline, variability, accelerations, and the decelerations. Be able to interpret contraction patterns, and be able to classify the fetal heart rate tracings into one of three categories. One of the ways to monitor is the external, which monitors the uterine contractions and the fetal heart rate. Its benefits is that it is non-invasive and can be used with intact membranes. Its disadvantages is that it's sometimes not able to adequately trace heart rate or contractions and detects frequency of contractions but says nothing about their strength. Next is the internal, which monitors the uterine contractions and fetal heart rate as well. Its benefits is that it has the ability to trace regardless of maternal habitus or position and can be able to quantify the strength of contractions. The disadvantages is that it is more invasive, only used with ruptured membranes, caution with patients who have HIV or hepatitis B or C, rare complications with placement. The basics. Each dark line represents 1 minute intervals. The graph, the graph above is the fetal heart rate, and the graph below is the mother's contractions. Features to describe the FHTs, the baseline, variability, accelerations, deceleration, interpret into of three categories. The baseline is the mean fetal heart rate, rounded to increments of 5. It is during a 10-minute period, excluding accelerations and decelerations. Its normal baseline is in between of 110 to 160 beats per minute. The baseline includes the bradycardia, which is 110 beats per minute, the tachycardia, 160 beats per minute, and it is indeterminate. Less than 2 minutes of baseline is present. The fetal trachycardia, normal variant prematurity, intraamniotic infection, response to maternal condition such as fever, dehydration, and many more. Fetal anemia, fetal cardiac arrhythmia, fetal hypoxia, and thyrotoxicosis. The variability is the fluctuations in fetal heart rate, beat to beat variation. Descriptors are absent if it is undetectable, amplitude range, minimal up to 5 beats per minute, and moderate if the amplitude range is in between 6 to 25 beats per minute. Marked is the amplitude range greater than 25 beats per minute. Accelerations is the abrupt increase in fetal heart rate. If the gestational age is 32 weeks, at least 15 beats per minute above baseline and must last at least 15 seconds. Gestational age, it is 10 over 10 seconds unless previously demonstrated to 15 by 15. The prolonged accelerations last at least 2 minutes but fewer than 10 minutes. Baseline change if it lasts 10 minutes or longer. Decelerations is the decrease of fetal heart rate below the baseline. The three types of deceleration is the early, variable, and the late. Recurrent decelerations recurrent if occurring with 50% contractions, otherwise intermittent. It is prolonged if it takes 2 minutes and baseline change if 10 minutes. Early decelerations is the symmetrical to contraction, mirror image of contraction, gradual decrease in fetal heart rate. Last 30 seconds or more from onset to nadir. It represents the vagal response to head compression and not a sign of concern. Late decelerations is the deceleration if the deceleration is delayed in timing, nadir following the peak of the contraction. It is a gradual fetal heart rate decrease. Onset to nadir 30 seconds. Represents uteroplacental insufficiency and non-reassuring. Variable decelerations is the abrupt decrease in fetal heart rate. The onset to nadir less than 30 seconds. Decrease in fetal heart rate may or may not be associated with contractions, and it represents cord compression, more likely with oligohydramnios and amnioinfusion. Common during labor and can be concerning if recurrent. Sinusoidal pattern, smooth sine wave pattern, cycle frequency 3 to 5 per minute and persist for 20 minutes or longer. And it is not non-reassuring with fetal anemia, so the sinusoidal pattern can occur after IV narcotic administration during labor. Uterine contractions is the number of contractions in 10 minutes, averaged over 30 minutes. Components to note is its frequency, intensity, duration, relaxation, time between contractions. And this is been reported by Miss Oraliza. Mon I did Next is the categorization of fetal heart rate tracings. Recommendation of three-tiered system. This is this have been developed on April 2008 and more standardized interpretation of fetal heart rate monitor strips is a dynamic process with determination of whether a particular strip is reassuring and what action plans should be taken, and then to evaluate at a later time. And categorization of fetal heart rate patterns is an evaluation of the fetus at a particular point in time. It has categories 1, 2, and 3. Category 1 is normal or good. Present if the baseline fetal heart rate is 110 to 160 beats per minute, and it is moderate baseline variability 6 to 25 beats per minute. Absent variable decelerations and late decelerations. Present or absent accelerations and early decelerations. Category 2 is the indeterminate or atypical. It's fetal heart rate patterns that are not category 1 or 3. Absence of induced accelerations after fetal stimulation. The category 3 is abnormal or bad. Present if it has sinusoidal fetal heart rate pattern or absent baseline fetal heart rate variability and any recurrent late decelerations, bradycardia, and recurrent variable decelerations. Lastly, the guidelines for reviewing fetal heart rate monitoring. We can say that the patient is normal if it is reviewed every 30 minutes in the first stage of labor and every 15 minutes in the second stage. Complicated patients every 15 minutes in first stage and every 5 minutes in second stage. Types of monitoring fetal heart rates or sounds. We have the intermittent auscultation. We are going to use a fetoscope, modified stethoscope attached to a headpiece, or a handheld fetal ultrasound stethoscope called a Doppler. It is used to listen to your baby's heart rate for a couple of minutes every 5 to 30 minutes or so. How often your provider listens depends on what stage of labor you are in and if your provider is concerned about your baby. This is usually done in low risk pregnancies. No maternal or fetal factors that place the pregnancy at increased risk for complications. Next is we have the continuous external electronic monitoring. It is the most common form of monitoring, that is external electronic fetal monitoring. This is when sensors are strapped to your abdomen. The baby's heart rate is monitored continuously, and instruments record both the baby's heartbeat and your contractions. This will help your doctor see how your baby is responding to the contractions. The recording doesn't stop. Your doctor can check it at set times and see how labor has been going overall. The sensors remain on your abdomen for all of labor. You usually need to stay in the bed most of the time. Next is we have the continuous internal electronic monitoring. In this method, an electrode attached to a wire is placed directly on the baby, which monitors the heartbeat. A sensor that is strapped to the mother's leg and the electrode is threaded through the cervix and to the uterus. There is there it is attached to your baby's scalp. The two can provide more accurate measurements of your baby's heartbeat and your contractions. This kind of monitoring is usually done if the external monitor isn't picking up well. This could be because you are moving around a lot or if you are obese. That's all for my reporting. I hope you have learned, and thank you guys for listening.